Hello everyone and good evening. Bonjour et bienvenue. Welcome to tonight's talk hosted by the Atom Society. I hope this stream finds you well and finds you still safe and healthy. Obviously lockdown is starting to ease, as I said in my email. We will continue to provide our talks online for the foreseeable future. This is partly because the new venue that we were supposed to be moving to is not yet open, and also to protect the health of our members and our speakers. But obviously we will provide updates as and when we have them, and we will always be asking for your feedback as well. So if you guys have any comments, questions, queries or concerns, please do get in touch, and we will keep that line of communication going. So, unfortunately for you guys, it's just me this evening. Alphonse isn't able to make it, and so it will just be myself hosting and presenting our speaker for the evening. So I hope you guys can cope with that. But first, how about we start with some science snippets? I haven't had any emails from you guys in the week. Hopefully you will be able to pop some in the comments like you usually do. I can kick them off with researchers have been looking at andors that are the largest soaring birds in the world, and they found that they only flap their wings in flight about 1% of their time. So they can weigh up to 15 kilos. And researchers found one bird flew for 5 hours, which is about 107 miles, without flapping at all, which I thought that was pretty impressive. And they found that 75% of the bird's flapping is associated with takeoff. So, yeah, definitely a way to travel. There's still no snippets coming through. So I had another one, a medical-based one. There's a medical student, second-year student at St. George's University in London, called Malone Mukwende, and he was motivated to create Mind the Gap, which is a booklet that he designed that demonstrates how certain diseases present themselves on the skin of non-white patients. He found during his studies that all of the imagery in his textbooks were based off white patients, and diseases can present very, very differently in skin with high levels of melanin. And so he has taken it upon himself to make this booklet, which is quite useful for anyone learning medicine, I guess. Oh, so we now have one coming through. Just wait for it to pop up on my stream from... Oh, Bob Anderson's giving us a few. Just give me 2 seconds for it to come through on my screen. The first one from Bob was that apparently over the next few weeks, the optimum launch window for Mars is open. So the US, China, and the UAE are all planning to send craft to look for clues about life on the planet. Could this be the next our generation space race? I guess it is. And the UAE, he says, launch was planned for earlier this week, but was postponed due to bad weather. So let's see how that progresses. Okay, well, if there's anything else, obviously you guys can comment in the feed, and there's Bob's comment there. You guys can comment in the feed during the video, and I can bring them up at the end of the talk as well. So, moving on to the main event. Tonight we welcome Dr. Audrey Gerard from the Kennedy Trust of Rheumatology Research at the University of Oxford. Audrey gained her PhD while studying at the University of the Mediterranean in Marseille, focusing on the negative regulation of primary and leukemic T-cell activation. Following her PhD, she moved to the Netherlands Cancer Institute in Amsterdam where she studied polarity proteins and T-cell migration. Following that, she moved over to San Francisco to work with Matthew Hummel at UCSF, and she continued to develop her interest in dynamics of T cells, looking at the molecular mechanism of T cell migration in vivo using 2-photon microscopy. I'm sure you all saw from the image of of her presentation screen that hopefully we're going to have some nice microscopy pictures today. She also, while there, developed a broader interest in the spatiotemporal behavior of T cells during infection and vaccination, and in particular described a specific period during which T cells directly communicate to control each other's fate. She moved across to the Kennedy Institute in 2016, where she heads up her group, the Spatiotemporal Dynamics of T cell Responses group, and that is where she continues her work today. So we're very pleased to have her here, and I will just pop her in the screen. Good evening.
Okay, good evening. Can you hear me? That's fine.
Yes, I can hear you. So we'll if we can't.
Okay, well, thank you so much for inviting me. I think this is a pleasure for me to be here and to talk about not only what I'm doing, but just in general about the immune system. This is really something that I'm fascinated with. And so today I actually wanted to use, as you said, the tools that we're using, which is the imaging, and tell you the story about how the immune system works, and really how all this basic and fundamental knowledge that we gain from this has really been useful to try to understand, immune responses towards cancer and trying to understand how to make better treatments towards cancer. So first, I would like to just start with something very obvious, which is what is the function of the immune system. And we all know that the immune system is here just to fight, pathogens, so something that does not belong to you. And it could be a very large, different pathogen. It could be a virus, toxins, fungus, bacteria, but it could also be like pollutions and also carcinogens. So the immune system has to fight all those different triggers and all those different injuries and those different, and if you don't have this, and most of the time, we know a lot about the immune system, for instance, with COVID, like we think about the immune system when you've got an infection and you feel sick and you don't feel well. But actually, most of the time, you don't even realize that the immune system is working and is keeping you safe. And this is really true, because if you do not have an immune system, you cannot live. And so this is a famous example. So this little boy, his name was David Vetter, and he was named the Bubble Boy. So he's born with severe combined immunodeficiency. And from birth, he didn't have an immune system. So he had to be placed basically in a plastic bubble that was made by NASA. And he could not get out. And actually, at some point, they even made some kind of a suit for him to be able to run outside a little bit. And the only cure for this, the kids like him, is actually to get a bone marrow transplant from someone else to be able to get immune cells. And actually, sadly, this little boy died at the age of 12 when they tried to make this transplant. And actually, during this transplant, he got infected with a virus, which is called EBV, and this virus called a lymphoma. So without an immune system, really, you cannot go outside, you cannot live. And even if you don't realize the little scrap that you have, you would die from it if you don't have this immune system. And in addition to this, is like, how do you deal with all the injuries? So you can have something going to your skin, to your lung, to your mucosa. And so the immune cells have to be spread throughout the whole body. And they have different homes, which are called the lymphoid organs, which is lymph node or spleen, Peyer's patches, and we have some all over the body. We also have some, like in the skin, in different other places. But what it means is that when you've got an injury, all those cells needs to communicate to be able to fight the injury wherever it is. On top of that, because they have to fight all these different triggers, what it means is that you need to have a lot of different types of immune cells to be able to respond to all the triggers. And so you have different types of immune cells. They're all displayed here. And actually, we find some almost, every month. You might find a new subset or a new, subtle differences that will be targeted toward a specific trigger. But just broadly thinking, what you have is that you have two types of immune system. You have one which is called innate. This is the first line of defense. This is something which is extremely rapid, but it's non-specific at all. So it's not that it recognizes which, if it's a bacteria or virus, it just knows that it's something that should not be there and is going to try to clear it as much as possible. And then you've got another type of response, which is called adaptive. So this response, then it's very slow. So it takes several days, whereas the innate response might kick in within 10 minutes, and I'm going to show you movies displaying this. The adaptive system is very slow. It's going to take a few days, 3 to 4 days, but it's very specific towards whatever trigger is trying to invade you. So it could be a bacteria or a virus, whatever. So how all those different cells, they have to coordinate their actions. They have to know which trigger it is, which cells to call, and they have many to do this. They have to communicate, and they have many different ways to do this. And so, for instance, they can be through direct contact. And so you can make the analogy of a private conversation where they really actually have to touch each other physically. They can have some interactions, which is called paracrine. So they don't have to touch each other, but they have to be near each other. So it would be kind of a conversation in a pub, for instance. And then they can also communicate over very long distances. And this would be more, as we're doing right now, through internet and having ways to actually spread the information really far away so that the cells need to come to where the injury is. So what I want to do today is actually showing you the journey that you have when you get an immune response. So first, I'd like to go with something very fundamental, being like, so if you have a wound, a little cut in your skin and you have bacteria invading, what's going on, which cells are triggers, and what do you need to happen to actually be sure that this bacteria is not going to go to your bloodstream and cause septicemia. But then I'm going to use this and this very fundamental knowledge to make the parallel with cancer and to try to see why actually the immune system sometimes recognizes cancer, but most of the time cannot control it. And so what are the parallel and differences and whether we can do something about it and how we use this knowledge to actually, get better therapeutics towards cancer. But so first, I'm going to start with this journey when you get your bacteria and your little cut and what's going on. So here, this is a movie showing immune cells, which are called the little green dot, which are called sentinels. They are called neutrophils. And what you see, I don't know if you can see my red little spot, but here, this is just a wound in the skin. So there is nothing else that's going on. There is even not bacteria. And this is what happens. This is within more or less 30 minutes. So here you go. You can see that within 30 minutes, almost all the cells that were close by actually just go towards this wound. And I don't know if you can appreciate this, so it's just looping so that you can see it. But in the beginning, you really have only 1 or 2 cells that might find it almost randomly, but as soon as you have a few cells that find it, all of a sudden you get this swarming and all the cells come here. And the reason this is happening is because you have some type of communication that's telling the cells, hey, I saw something that's not normal, you have to come and check it out. And so how is this all initiated? And in this context, actually, even without bacteria, it's very simple. Actually, you have, because of the wound, you have some cells that have died. And so because of this, what happens is that you have things, I'm showing with my, you have things that are going outside of the cells that should not go outside of the cells. And this is your DNA, for instance, or some other stuff like actin. And so because this is outside, and those sentinel cells, which are called neutrophils, they actually can recognize this. And as soon as they see that, they know that something is not right, because you should not have this outside. When there is a bacteria, they can also recognize the bacteria specifically. So the bacteria might express, several lipids, for instance, that our body do not express, and they can recognize that, for instance. And so that would be the first trigger. And then when that happens, it unlocks actually some signals, which is telling the cells, which is sending the cells to the neighboring cells, being like, hey, there is something that's wrong here. And what you get, it's actually an signal amplification to recruit as many cells as possible. So the first one, which could see the cut, actually recruited, signals and recruited the first one. The first one can respond to this, and then they're also going to signals, and so on, and so on, and so on. And so what you get at the end, you get really some kind of a gradient, and the cells are going to be drawn to this. So this is another example where here you see the cut in the middle of this movie. The sentinel cells, the neutrophils are now in red, and in green you get other types of cells. So you see them as soon as they sense the wound coming towards it. And then you see something else that's happening slower than that. You see those other cells, those green cells, that are coming and surrounding the first cells. They don't get in the middle. They just go around it. And I found it fascinating, actually, just to see how this is all organized when you look at this. This is just looping again. So you see the neutrophils coming, and then you get those slower cells slowly going around it. So what are those cells? Those cells are actually bacteria eaters, too, as the first sentinels. They call macrophages. And so what those cells, the job of those cells is to eat the bacteria with the sentinels. And their other job is also to signal the path to infection. To do that, they use something which is called molecules, which are called cytokines. And so what they're going to do is that they're going to help amplify the system by using a very long-range communication. So what happens is that, when they get around this big cluster, then they signals, and then you get a recruitment of other neutrophils and other macrophages. And this recruitment is also like amazingly fast and specific. So here in the middle, you see a blood vessel, and this is the skin next by, and you're going to see those cells, it's going very fast, and all of a sudden you see those cells stopping as there is an injury, and you're going to see them very slowly moving, and all of a sudden they're going to enter. I'm going to show you another movie, which I think we see it a little better. Same thing, in the middle, you've got the blood vessels, and all of a sudden, you're going to see that they sense that there is an injury up there, and you're going to see all those neutrophils, all those sentinel cells, actually just going up there. And so those two types of cells, those neutrophils and macrophages, then their job is just to be here, check that there is this wound, and just check that there is no bacteria or microbes, and if they see one, they just need to kill it. Basically, they can do that by two ways. The first one, which both cells share, is to just phagocytose the bacteria, for instance, so just engulf it, and then they're just going to kill it inside the cells, and the cells might die, and then it's going to be picked up by other cells that are just going to clean it up, if you want. Another way that they can do it sometimes, which I found so beautiful, is that if the microbes are actually too big, or if the cells cannot actually take it up, what they're going to do is that they kind of commit suicide. So what they do is that they're just going to shut out all their DNA, and the DNA is something that's going to be very sticky. And then the bacteria is going to be stuck into this, and they're not going to be able to get out. So this is a process which is called mitosis. So this is how they kill the bacteria. So if we think about this journey, actually I just showed you just this first step. And this is enough, usually, just to not get a spreading infection. So you've got those first sentinel together with those macrophages, both bacteria eaters, which are all gonna just control the bacteria and also tag the infection site. However, sometimes this is not enough. And a bacteria, for instance, can enter in a cell and it can stay there and it stays hidden. But then what it means is that this innate immune system, this very quick one, cannot clear the bacteria. So this innate system, it has different ways to control the bacteria. First of all, which I haven't talked about, but you can see when I talk about the wound, is that we have physical barriers, right? The skin is a physical barrier, the earwax, the stomach acid, and all stuff, which is just going to kill or make it in such a way that the bacteria, viruses, and fungi cannot invade. But they constantly try. Your skin is covered with bacteria. When they get around those barriers, you get those innate immune cells, which kind of like do like a garbage man and really trying to clear all that. But when they need backup, they're going to call the adaptive immune system. And the way they do that is that you have a third cell type, which I call the messenger. It's called dendritic cells. And what it does is that it can take up the bacteria like the other cells, but it does something very specific, is that it's going to cut the bacteria in a lot of little pieces, which we call peptide, and then those pieces, they're going to present it at their surface. They're going to put it out. So the fact that they cut the bacteria in little pieces, this is actually a signal to tell those messengers that there is something and that they need to move out of the skin. And when they go, is that from the skin, they go to the nearest lymphoid organ when you're going to have a lot of the adaptive cells that are just circulating in those through those organs. And so then those messengers, they're just going to activate this adaptive immune response. So am I not going to talk about all the players of the immune adaptive response, but basically you have cells that are called the helpers. What they do is that they're just going to help the other two cells below to get primed and go to wherever they need to go. Then you get this cell, which is called the B cells, and the job of that cell is actually to create antibodies that are specific to the trigger, so that bacteria or virus. And so what it's going to do is that it's just going to create those antibodies just to identify those triggers, those bacteria that need to be killed. And I'm going to spend most of my time talking about the last adaptive immune cells, which is called a killer. It is a T cell. And what it does is that it can find the cells that are infected by your virus or your bacteria. And what it does is just going to kill those cells to be sure that they're all that there is no bacteria anymore. So how this is happening, as I said, this is something which is very specific, and this relies on actual physical contact between the cells. So in green here, you have the messenger that just have this, this little bacteria in them, and now they come and be like, hey there, I've got something in me, this is not right. And you see in red, you've got those killer T cells, and they just go around and they touch it, and they're like, okay, do I sense something that I recognize? That's not self. Okay, I don't. But here in the next, on the right window, you get the same thing. But here, those killer cells, they did recognize that there was something wrong, so something which is not self. And then they stop, and they contact each other for a very long time. And this, as I said, this communication is very specific. And the reason it is very specific is because those killer T cells, every killer T cell is different. And it's called, they have like little sticking around receptors, which is actually simply called a T cell receptor. And this receptor, it's this little bit that's going to recognize your bits of bacteria. And some cannot recognize it. They don't fit. It's like, you can think about it like a puzzle, for instance, and the puzzle, the two pieces might not fit, and they're not going to recognize it. They're not specific for this bacteria, so they don't have to be, in the immune response, so they're just going to move on. However, if it clicks, like the two pieces of a puzzle, if they really fit, then what it means is that it tells that killer cells that, hey, there is a little piece of bacteria around here, I can recognize it, and I should go and try to kill the cells that are infected with this. And the better they actually interact, the better they interlock with that messenger cell, actually the better killer they are and they become. And then you get, again, an amplification step. So if they got this very contact, so then they're going to start proliferating. So from one cell, you're getting actually, you've got an amplification of about 100 to 1,000 times often. And so you get a lot of killers that are very specific to your trigger. So here the bacteria, but something on top of this is that the messenger is also giving them the postcode of where those cells need to go. Otherwise, how do they know where the trigger is? So you get this message. So they know what they have to kill and they know where to find it. So this is what's going to happen. And then this postcode actually uses whatever you remember, those bacteria eaters that amplify the immune response to start with. So that's what they recognize. And so they're going to do exactly like the first wave. So because those bacteria eater left a signal path to the infection through molecules which are called cytokines, the killer T cells can find it. And instead of being spread throughout the body, they're going to go and be concentrated exactly at this place. And so when you look at this, this is the innate immune system. And when this is not enough, you get the messenger that's coming. It's activating those killer T cells, which are very specific to the bacteria. They travel to the site of infection, thanks to the tagging that has been done by the macrophages, and then they have to kill. And then I'm going to show you a picture which I found, a movie which I really like. It's from a group in Cambridge, which also in blue you have a cells. It could be cancer cells, it could be infected cells, and in green you have those killer T cells. And you can see that they recognize that infected cells or tumor cells, and then you can see that they interact. Oh, I'm going to try to play it again. Oops. That they interact with this, and you've got all those red little spots. Those are actually killing granules that as soon as they recognize it, you see it very nicely here. They're just going to deliver those granules to that cell, and that cell is going to die. And so because this is very specific, what's going to happen is that those killer cells, they're going to kill only the cells that have been infected with bacteria. So all the ones that I tagged with the little red thing. So this is a very specific thing because those killers, they're extremely potent, and you don't want them to go around and kill all the epithelial cells, all the healthy cells that you've got around. You really want them to do only this. So really, this is really the journey that's probably going on in your body, almost very often, almost every day, at least for the first part, and that you don't realize. And this is something, you might have like different cells or different timings or different, but really this is just like the dogma of this is happening. And so how does it relate to cancer? And do you have, an immune response to cancer? And so just, as a definition, cancer is a condition where cells in a specific part of your body are going to start to grow and they reproduce without stopping. And so those cells can invade and destroy the surrounding healthy tissue, including organs. So you start with these normal cells, it's going to start to be mutated, start being abnormal, and then they're going to start proliferate, and they don't stop. Nothing can make them stop. And then if there is some angiogenesis, if they have some blood vessels coming to them, then they're going to be able to invade. And so when you think about it, a tumor cell is self. It's not really an intruder, right? So the immune system should not really recognize those cells because that's your own cells. They just proliferate too much. However, we can really make the immune cells recognize the tumor. And the first evidence actually started in the 1890s. It was a doctor, which is called Dr. Cowley. He was a bone surgeon. And actually, this doctor found that some patients that had very big tumors that could not be operated, he found that the tumors can just disappear if those patients contracted an infection that was caused by Streptococcus. And those patients would have like a big fever, painful rashes, but somehow the tumor would disappear. And so Dr. Cowley was really fascinated by this. And so what he tried to do at that time was actually just to take that Streptococcus and inject it in the tumor of some patients. I think that was the very first patient that was treated. And so he had to repeat that, I think, over 5 months, but the tumor eventually shrank. However, as you can imagine, that actually bacteria could be deadly. So some people died. There were a lot of side effects. It wasn't working for everyone. It was kind of a big mess. But it was the first evidence that you actually give a bacteria and you've got a tumor that shrinks. And at that time, they didn't know really why this was happening, right? But so what Cowley decided to do was actually to use dead bacteria instead of live bacteria, and it indeed reduced the risk of death. but they still had those like side effects, like a lot of fever. And this mixture became known as the Cowley's toxin, and that's the first kind of immunotherapy that existed. Although at that time they didn't know it was immunotherapy. Actually, the hypothesis was that what they thought was like tumor cells were actually caused by a virus, and they thought that the bacteria would kill the virus. And what happened after this is that, as I said, a lot of patients would die because of this, anyway, this treatment, so it didn't seem worth it. And then a few decades later, actually the chemotherapy came up, and then they thought it was safer actually to use compared to the Cowley's toxin. So no one really looked at this anymore, but actually what they didn't know is that when they injected this toxin, what they did is that they created a big inflammation, and they created an immune response which was then able to cure the tumor. So this is just an example of without and after injection of this toxin. So this was really one of the first evidence. And then on, what also people realized is that all the players of the immune response that I talked about up to now, you can find them in the tumors in quite some cases. So the T cell, which is the killer T cell, the macrophage, the bacteria eater, the messenger, the dendritic cells, they're all there. So, and studies have shown that, the cycle that I showed you for the bacteria and the wound and what's going on, actually you can find it for tumors. So actually the tumors, they might die and they release some DNA, and then you get the innate response, you get the messenger coming, activating those killer T cells, and the killer T cells coming up. So we see this happening in quite some cases. So why is it not effective? And I'm going to show you 3 examples showing why this is not working, and how we use this knowledge to try to make it work. The first thing is that actually tumors, even if there is an immune response, often shield themselves from the killer cells. And so here on the left, this is called an inflamed tumor, and this is what you want to have. This is a perfect case when you've got cancer cells in white, and you've got immune cells, so killer cells in red, and they are in the tumors. And usually patients that have tumors with this phenotype have a better prognosis as baseline, and after immunotherapy even better. But then you also have quite a lot of cases where you just do not find any immune cells in that tumor. And this could be due to different things. So either the tumor is not recognized as foreign. That's what I said in the beginning. Actually, it's a proliferation of your own cells. So actually your immune system don't see it as something that's bad, right? So it doesn't do anything about it. Or what happens is that sometimes you have the killer T cells, but they don't have the postcode that I was talking about. So they don't know where to go, and they actually, the tumor does not want the T cells to know where they are. So they're actually hiding themselves. And the third one, which is an interesting one, is the fact that sometimes the T cells, the tumor cells, the tumors can really shield themselves. And what you're going to see is that you're going to see a lot of immune cells, but they just stay around the tumor. They cannot get inside and kill. And this is an example, an image. Oops. What you really see in 3D, you really see, so the tumor is in red, and in green you've got all the immune cells, and you can see that they're already around it, and they cannot penetrate, and so they cannot efficiently kill. And here I'm just going to spend like a few movies just to show you, at least during metastasis, how this, potentially can happen. And this was a study that I participated in, and I thought it's just a beautiful imaging that was done by those people. So this is metastasis to the lung. So what you're going to see, so in red, you see the lung vasculature. You're going to see in green the tumor cells coming into the lung. And we also have a dye in blue, which just highlights the blood flow. So you're going to see the blood flow coming, and you see those tumor cells just coming and being trapped. Because in the lung, this vasculature is actually too thin for the cells to get in. Tumor cells are very big, okay? And most of the time, those cells, so on the lower part, they will just die. This is just what's going to happen. You've got the flow and the shear flow from the blood, and the vessels are too small, and so eventually they're just gonna die. But sometimes what they do is that while they are trapped, the tumor cells start to release some fragments of themselves. They are called cytoplasm, microparticles, exosome. People give like a lot of different names. So here the lung vasculature is in blue, and you see the tumor cell in green, trapped in the vessels. And look at how it looks like. So the cell is alive, you see its nucleus, and you see it spreading thin, and actually just, you get bits of themselves. So as I said, microparticles, those little fragments, it's just gonna come out of the cell. And you might think that this is not necessarily a good idea to have little pieces of yourself, that can be recognized as foreign doing this, but you'll see that it's actually a very clever way to do this. So they have those little blebs, those little particles, and actually those particles are picked up by, the bacteria eaters that I was talking about, during like the normal cycle of an immune response. So here, those bacteria eaters are in blue, and you've got those little fragments of tumor cells, and actually you see them being taken up here, if you follow the arrow, you see them being taken up by those innate cells. And when you see this, you're like, okay, so that's fine, like the immune response just kicked in, they're gonna go and recruit the killer cells and everything is gonna be fine. However, this is not exactly what's going on. I mean, it is actually what's going on, but something else also happens, is that exactly for what happens for the bacteria, actually those innate cells, they cluster around the tumor cell. And you see them, you see the tumor cell in red, in green, and you see those innate cells that picked up little fragments of the tumor cells in blue, and they actually surround the tumor cells which is now in the lung. It's not, it managed to get into the lung. And now you see those immune cells that are around it. And so what happens is that they just shield it. They cannot kill the tumor cells. It's too big. It's not a bacteria, but somehow it shields themselves. And then the killer cells cannot access it. And this happened despite the fact that the killer cells are generated, that all this cycle actually happens. We do see actually messenger going to the lymph node, to the organs where the killer cells are. So here they are in red. And you see they are in those organs, they are here, and you can see the killer T cells in green being, they are proliferating, they are interacting with those cells. So this is all happening, and there is no issue with that. But somehow those cells cannot come and invade and kill the tumor. So this is the one way that there is actually a lot of research which is going on right now, that people want to try to understand how to, break this shield and make the killer T cells enter. So this is the excluded mode, and there is a lot of things. So the second way, actually, the T cells, the tumor cells, kind of like are not priming an immune response, is that they can hide whatever can be recognized by the killer T cells. So here, you've got a tumor cells and it has a mutation, and a mutation would actually be something that then your body would recognize as foreign, right? Being like, oh, you shouldn't have this. This is not how it's supposed to look like. So then your killer T cells could come and be like, hey, you're not normal, I'm just going to kill you. Okay. So this is the best case scenario. But then the tumor is going to adapt to this. And when they do, is that all those little pieces that they present, the peptides, whether it's mutated or a normal one, they're just going to take it out inside. They're just not going to put it outside anymore. And so the T cells, the killer cells, has nothing to, they don't know that it's a tumor cells anymore. So they're just not going to attack. So this is the second way where really, the T cells are not, the killer cells are not efficient. Something that's interesting though, and that we don't really understand, and it's just coming out for the past year or so now, is that actually you do have other types of killer T cells, which then are actually here and they recognize the fact that tumor cells, now it has nothing at the surface, right? It has nothing to say like, hey, look at me, I'm a good person, or I'm a bad guy. And usually those cells that are called natural killer cells, they recognize the fact that there is nothing, and this is not normal because every cell in your body is supposed to have some. So they're supposed to recognize that, and they're supposed to kill it. However, we know that in tumors, most of the time this is not happening. And, like they hide themselves, but the natural killer cells, the NK cells, do not attack. And it hasn't been given a lot of attention up to recently, where people are like trying to understand why this is not happening and whether we can leverage this to actually do better therapy. And the last example that I wanted to talk about, and it's probably one that you know, it's when the cancer uses the killer cell off switch to actually stay alive. So you've got your killer cell here, it recognizes the tumor cells, it says, you've got this locking system, and it's like, okay, I'm ready to kill you. However, the tumor cells is going to express an off switch. Every killer cell has different off switches, which are here to prevent too much killing of the cells around them, to prevent what we call immunopathology. If you do not have this switch, actually the cells can become autoimmune, and they can, get a little overwhelmed, and they might start killing everything. And the switches, they're called checkpoints, and they're here to actually avoid that. And the tumor cells, well, because it's cells from your cell, but cell cells, and they use to express this to actually avoid being killed. And this knowledge actually led to the Nobel Prize of Medicine in 2018. This was given to Jim Allison and Tasakungo Unjo, who actually found two of those checkpoint proteins, which are called CTLA4 and PD-1. And so what they found is that you can actually block this off switch. And if you block this off switch, then you get an immune response. I think the reason this Nobel Prize was really, I thought they really deserved this Nobel Prize, is because they really figured out from, the biology, from what's this checkpoint and those switch off, how is it working normally, and then realized that they could leverage this during cancer. So they really figured out both from like the basic understanding, the fundamental understanding, to actually get cure is not the right word, but actually get a treatment, a viable treatment for cancer. And here on the right, what you can see, this is usually those treatments are given for metastasis patients. So it's like grade 4 patients where there is no other medicine which is really working, and standard therapy, the years after diagnosis, the survival is going down drastically. However, with immunotherapy, you see something interesting. You see actually you have about between, depending on the cancer type, you have about between 10 and 30% of the people that are actually responding to this immunotherapy, which is actually a lot because those patients usually have a survival time of about 6 months. And in 30% of those patients, the response is long-term. So it's actually, some of them are just like you cannot see the tumor anymore. Or it doesn't work. So it's really, it works in like 10 to 30% of the patient, or it doesn't work. It's black and white, almost. So so what it shows is that you can really use the immune system and train it to go and kill that tumor cell, but at the same time, it's working only is working only in 30% of the cases at most. So which means that there is a lot that we still can leverage to try to make better immunotherapy, or not better, but just different. And so this is more or less what people are working on right now. And they went out of this, people are slowly getting out of those two checkpoints and trying to find other ways, trying to understand where the immune response is not working during cancer and how to make it work. So, like the lack of tumor antigen is one which is actually very difficult to overcome. But usually, what happens is that the messenger, the dendritic cells, is not working properly. The tumor cells just kind of inhibit it. And some people have been trying to do vaccines. actually with those messenger, just to be like, okay, if you cannot be primed by yourself, we're going to help you be primed because we know the tumor antigen, and then you're going to do and go and do your job. So this is one area of investigation. The second one is that sometimes the T-cell priming is not efficient because of some of those checkpoint blockades, but you've got a lot of other blockades, which is actually looking at right now. So they're trying to remove the checkpoint blockades. Something else that people are looking at is that sometimes it's not that there is no tumor antigen, it's just that because it's in a cell, you don't have a lot of T cells in your body that can recognize it because you're not supposed to recognize self. So people are able to actually engineer a T cell receptor, a receptor that will recognize this antigen, put it into the T cells, and then inject those T cells. So it's called CAR T cell therapy. The other area of investigation is the fact that sometimes, as I said, the killer T cells, they are just stuck. Either they don't have the postcode, and it's trying to understand how to make this postcode, how to make them go to the tumor, or why they are outside and how to make them get inside the tumor. And the last one is it's finding ways of like how is the killer T cells inhibited. And this is the example also again of the checkpoint blockades, but you do have also other cells that are implicated in other areas, which is a big area of investigation. So just when I put that back into a timeline, so you do have actually the first immunotherapy that happened, which was with the Cowley's toxin in 1893, and after this, really nothing happens. And as chemotherapy really started being used for cancer treatment, people didn't really want to use this toxin anymore. And it's really the daughter of this Dr. Cowley's, which really actually funded an institute, the Cancer Research Institute in the US, which is still one of the main cancer institutes, and to really try to understand why this was working. And this really started to give a little boost for this. And you see the next actually kind of immunotherapy, which was to use those cytokines, like those little trays that they leave, or the way the cells communicate with each other, to try to make a better response. And that was in the 1980s. But those had a lot of side effects and actually were not used. And the clinical trials were very not necessarily good. It could really go either way. And I think it's because, they use those little molecules to communicate in various different ways. So then, they would become very susceptible because it's not specific. They could, become susceptible to infections, for instance, or things like this. And then it's like really the field of cancer immunotherapy really, really took off after those checkpoint blockade and the Nobel Prize that I just talked about. So it really got quite more than 100 years to actually go from the very first evidence that they could have an immune response to cancer to try to get some therapeutics actually. And right now you see a variety of immunotherapy which is in place, and I talked about most of them. So the cytokine, the checkpoint inhibitors, to making vaccines, so just forcing the cells to get primed toward the tumor, this T-cell therapy or CAR therapy. And this is just to illustrate how this very big boom, and it's been just in 2 years between 2017 and 2019. And so every round, dot is just one therapeutic, and the number and the bigger the circle, the higher number of clinical trials has been done for this. And so every circle is a different target, let's say. Immunotherapy target. And so you can see in 2 years, not only you increase the number of clinical trials for certain targets, but also you start seeing really a higher number of targets and a higher number of clinical trials. And people are also really into combining different, being like, okay, maybe I'm gonna make a better killer cells, but it can still cannot come. So we have to the tumor. So we have to combine two of them to be able to really clear or at least control the tumor. So this is it. This is just what I wanted to talk about. So here I'm just going to finish up just to show you. So as I said, we are in the University of Oxford. I'm not interested in everything that I showed you, but we're very interested in like the fundamental immune responses, that you could have for bacteria, for instance. We're interested in the killer T cells and how they get their messenger, how they interact, how they communicate with each other, and then how they go back to actually clear bacteria. And we're also interested in this in the context of cancer. So with this, I'm just going to stop. I'm probably going to stop sharing because I don't see anyone, and it's very confusing. Thank you so much.
Thank you very much, Audrey. That was really, really interesting. I have a special soft place in my heart for advanced microscopy, so I thoroughly enjoyed all of those videos. Thank you very much for that. Hopefully questions will start coming through in a moment. I have one myself before, while we wait for our viewers. I personally had never actually heard about netosis. I thought that was fascinating. Could you give an example of when the immune system, when netosis might be triggered in deference to, for example, phagocytosis? Like, why would netosis happen and not phagocytosis?
So I think what's my understanding, because it's not necessarily the cells that I study, is that if they cannot get phagocytose, the bug, they might induce netosis. So if they feel that there is a bug and they cannot phagocytosis, so it could be due because of the size, because the bug is too big, or just because for any other reasons they cannot phagocytose. So then that's what's going to happen. Then they're going to do this, and it's actually pretty dangerous for them to do that, because then you induce a big inflammatory response, which can be dangerous for the body. So I think if they can avoid it, they will.
Yeah.
But if they cannot control the bacteria, they might do this.
Okay. Cool. Thank you very much. So we have had a few questions come through now. So the first one is from Sarah Bailey, who asks, why have the number of studies on CD19 increased so much in 2 years?
I don't know. I think the studies were actually for the CAR therapy. It's actually one of the only situation where it's working.
Yeah.
So I think what happens is that CAR therapy, so when you force the T cells to recognize something specific, it's been very useful for lymphoma. And so actually the lymphoma are going to recognize this CD19, and they're going to kill the lymphoma. They also kill the normal B cells, but I think they can make infusions of antibodies to uncover this. But I don't know why you have this. I think it was just working, and I don't know if there is a more specific reason than this. And it's true when you look at this, but when I look, when I am interested in my, when I looked at, it's not that I have the feeling that I see more of them either. So I don't know if there is a specific reason that I don't know of.
I guess as well, because as you say, CAR T therapy, CD19 is one of the few cases where it's actually working, and we have it.
Yeah, exactly. Yeah.
You're going to get a bunch of papers coming out about the applications of.
Yeah, exactly. It might just be just at this time, but then it's going to come back as other are going to pick up. Yeah.
Okay, thank you very much. And then we have a question from Michael, who asks, can you explain what a cytokine storm is, please?
Yes, I mean, I can try. So a cytokine storm is actually, when I talked about the inflammatory response, is when your cells cannot stop. Your immune cells, they're going to send the cytokines, or the little messengers that the cells use to either communicate with each other or also to kill some cells. So, they can be used both ways. And what happens is that sometimes the cells are going to produce so much that they don't know, they don't have the off switch. And what happens is that you have too much in your body. And you might be referring to COVID right now, because this is one of the severe form, one of the hypotheses that this is what's happening. That actually you even don't have, I'm sorry, I've got my cat here. Sorry. you might even not have the virus in your body anymore, but the immune system cannot stop, and so it just produces too much cytokines, and it starts killing your own cells, your own body. So this is an issue, and there has been a lot of people are trying, to stop this. And so you've got the anti-IL-6, for instance, which is one of the cytokine, which is part of the storm, and some people think almost initiate the storm. So just trying to block it. Also corticoids, and this is something which is coming from the big trials at the University of Oxford, which show that actually, this is an old medicine. My goodness, sorry. But it might work, actually. I don't know if that was good enough, but tell me if you want more.
Thank you very much. I'm sure Michael will come back if he has any more questions. Thank you very much for the explanation. We do have a comment rather than a question from Liz, who just says thank you from a complete non-scientist for a very interesting and understandable talk.
Oh, thank you.
So, always nice to get those kind of comments. So I have a question from my partner who's sat next to me right now. And so he said most solid tumours upon diagnosis have complex architecture due to different cell lineages within that tumour. And how does that cell plasticity affect the chances of immunotherapy being successful? And how many surface markers can you target before it becomes unsafe?
So, I mean, when you talk about the plasticity of the tumor, do you talk about the heterogeneity of the tumor or more the stiffness? If I can.
It's the intratumoral heterogeneity rather than the heterogeneity between patients. So you've got different types of cells within the tumor.
And it does, I think it does definitely work. It is important, right? When you've got like very hypoxic region, for instance, we know that this inherently is going to kill it. Your T cells are not going to work because it's an hypoxic environment. So in all those areas, it's actually going to be very difficult to get anything to work. And it might actually, part of it might be why we see some exclusions go around. So it definitely does play in it. However, it hasn't been very so far, studied too much. There are actually interesting studies coming out, but no real. We're just trying to understand what this heterogeneity is to try to see how we can play with it. But so far, I don't think there has been like a real link, like, oh, if you have this heterogeneity, you might not respond. I think it's more linked to my understanding about more like I'm losing my words. The hypoxic regions and things like this.
Thank you very much.
Yeah.
Okay. Okay, we don't currently have any more questions at the moment. I'll just give people a couple minutes in case they want to, if they're typing. Just to point out, when I was talking the science snippets earlier, Caroline Gregory did ask if anyone had seen the comet. There is a comet going across the UK at the moment. It won't be back for about another 6,000 years. And apparently, according to Caroline, the best chance to see it is tomorrow night. Although Frank did ask, does anyone know if it's better tomorrow after sunset or before sunrise? So if anyone can come back with that answer, that would be great. Sarah has come back with another question for you, Audrey. So Sarah asks, are there any particular cancers that are more responsive to the checkpoint inhibitors, the 30%, for example?
Yes, definitely. So actually, the better predictor of a cancer, of the success in immunotherapy, it's whether that tumor has mutated a lot. And it makes sense when I talked about this whole cycle. It's because if it has mutated a lot, you've got actually more chances that your T cells are going to recognize it as not self, and then it's actually going to work. So and we talk about neoantigen. So when you've got mutations and then you make so then you make proteins that you don't have in your normal body. And actually, the more, there is a very good correlation between, it's actually the best correlation that we have right now between this this mutation of tumor antigens and the response. So melanoma is probably one where all those type of tumors that are characterized by a lot of mutation. Actually, that's where the immunotherapy, at least the checkpoint blockade, works well. So melanoma is one of them. Yeah.
Thank you very much. Michael has come back and said thank you. He has a follow-up question that he'd heard cytokine storm is when the immune system goes into overdrive and causes a rheumatological condition. And is this what dexamethasone attacks? I guess he's asking how does dexamethasone work?
Yes. Yeah, exactly. So it's when the immune system goes overdrive, so you've got cases like COVID, where it's just like very systemic and actually very life-threatening. You might die from it, but otherwise you get all the autoimmune diseases, right? And it's a case where actually your body recognizes some of your cells, they think it's foreign and it's just attacking them. So RA is one of them, and indeed, dexamethasone is one of those treatments to try to just dampen the immune system. That's right. Something that's interesting, it's related without being related, is that when I talk about those checkpoint blockade, and I say that what we want to do is actually remove that switch off. People that respond very well to those, usually they start getting some type of autoimmune reaction. And there is actually a very good correlation, and people might get like gut issues, but which is not like a Crohn, like people would have if they had Crohn's disease, but they would still get an autoimmune disease which is linked to the killer T cells, which all of a sudden start attacking the gut. And it's really interesting. This balance is actually very interesting and very difficult to keep in check. Being like, okay, I want to attack the cancer, but I don't want to attack, my own cells. Yeah.
If it's specifically the gut, could that be because that's where we have normally cells that have a really high turnover rate in the same, they're proliferating a lot in the same way that cancer cells might? Is that perhaps why?
I'm not sure. I don't think there is much about it. I think it's not only the gut, but the gut is definitely one of the most, side effect, where you're going to find the most side effect of checkpoint therapy. Why is that? If it's because of the microbiota, because you do have a lot of I'm not sure, but I think people are starting to look into this to try maybe to mitigate all those side effects that you get with actually a good response, anti-tumor response.
Thank you. So I think maybe that's the last of the questions, but a few more comments just coming back saying thank you for the great talk, and that it was wonderfully interesting. Caroline has also come back about the comet. Frank, if you're listening, they think the best time to view it is after sunset tomorrow, northwest and below 20 degrees. So if anyone's interested, that's quite a specific description of where to find the comet. Okay, so thank you very much again, Audrey, for the talk. It really was very interesting, and I loved all the microscopy. And by the looks of it, our viewers have watched it and have enjoyed it as well. So great. And to everyone, all of our Atom viewers out there, we will see you in a month. Bye.
Okay, thank you so much.